procedure, and the samples were sent for pathology, which confirmed endometriosis and diverticulitis as well. What's the pathophysiology of diverticulitis?
So diverticulitis occurs because there's an increase in intraluminal pressure. It typically occurs in the sigmoid colon. And what happens is the mucosa and submucosa penetrate through the vasa recta in between the tena coli.
And what's the anatomic background for that?
The anatomical background would be that there are two layers of mucosal wall, which would consequently mean that there is a weakness in the wall, and therefore you get herniation of the diverticular through, which can then become inflamed.
So you mentioned the intra-abdominal pressure. This is obviously very important to mention the unique. So the outer longitudinal layer is not a continuous layer. As you look at this image, you have three small bands as an outer longitudinal layer. It's not a continuous layer anymore. That's why these areas are actually weak, and this is where diverticular disease could happen. The other thing is into the inner layer, you have the vascular structures and the nerves, so vein, arteries, and nerves, all right? And then they come out of the wall, so they create a pressure point or a puncture point. And this is where, can you hear me?
Yes, this is where I can hear you. Can you hear me? Hello? I can hear you.
The whole explanation for it.
Yes, I can hear you, Dr. Mansur. Can you hear me?
Yeah, I can hear you now. Go on.
So then you were just saying that there is essentially three bands of muscularis propria in the longitudinal plane, and that it's a non-continuous band, and therefore you've got a bundle of nerves, or veins, arteries, and nerves that can essentially herniate or penetrate through, and that subsequently can then become inflamed.
Correct. This in addition to the increase in the intra-abdominal pressure, all right? So intra-abdominal pressure on its own will not be enough. So the unique anatomical structures and the presence of vasa recta is actually very important as well to mention. All right, so how neutrophils migrate to the site of inflammation?
So neutrophils can migrate to the site of infection in 4 stages. The first stage would be rolling and tethering. The second stage would be that they transmigration. So they would then, second stage would be adherence to the endothelial wall. Then we get transmigration of the neutrophils to the site of inflammation. And then finally, we get transmigration to the site of chemokines, such as interleukin-6 and other cytokines that are present.
That's right. So migration, rolling, adhesion, transmigration, and finally chemotaxis. And then the process will continue by phagocytosis through the phagocytes, and at the end, destruction of these phagocytes and the resolution of the inflammation at the end. All right, but you want to mention the migration happened through 4 stages: rolling, adherence, transmigration, and chemotaxis. You want to mention the word chemotaxis?
Yes.
All right, good. What is the lifespan of neutrophils?
The lifespan of a neutrophil is 5 to 7 days.
It's about 7 to 14 days in the bone marrow and 12 to 24 hours in the circulation. All right, so this question, there was a lot of fuss about it because everyone who said 7 to 14 days and stopped there didn't get the mark. All right, so you want to be very specific. And the bone marrow, it's 7 to 14 days, and the circulation is 12 to 24 hours. All right. A few days following the surgery, the patient developed left inferior fossa collection. What do you think is going on?
So here I would be worried about a pelvic collection or abscess that has been retained, or I would be worried that a diverticulum has ruptured.
I want you to go back to the stem, right? Do you remember the stem? So the stem said the patient had diverticular disease and underwent Hartmann procedure.
Yes. So given the fact that the patient has a Hartmann procedure, I would be concerned with, or my differential diagnosis would be a intra-abdominal collection, such as a abscess. I'd be worried about a hematoma. I'd be worried about an anastomotic leak, and also I'd be worried about a ruptured diverticulum.
So retained collection, diverticular abscess. I think I actually need to add anastomotic leakage here. Anastomotic leakage, I think, is very important to mention here. All right, what antibiotic to start the patient on?
So I would like to consult my local microbiologist, adhere to local trust protocol. In my current practice, we currently use AMG, which is amoxicillin, gentamicin, and metronidazole. However, in certain circumstances, you can also use clindamycin as well.
What's the initial management of acute diverticulitis?
So this can be based upon, so first of all, I'd like to do a full history and examination for the patient. I'd like to manage the patient according to CRISP protocol and do a full examination. like to organise some investigations, both non-invasive and invasive. The non-invasive would be doing a full blood count using these LFT CRP. I'd like to also do an abdominal X-ray and an ABG, including lactate. And the invasive investigations I would consider would be a variant and rigid sigmoidoscopy. Measurement can then be based upon Hinchy classification, which is 4 types. 1 and 2, which is typically an abscess. We can manage them conservatively, keep the patient nearby mouth, IV fluids, bowel, preparation of good toileting measures, and antibiotics. And if the patient perforates, then we can do a Hartmann's, and going back to the abscess, they can be managed either with open drainage or CT radiologically or interventional radiology guided drainage as well.
Very good. So very well done. So I asked you what's the initial management, and you went through CREST protocol. So that's very well done. So you want to do a full A2 assessment. You mentioned history, examination, investigation. You used a very good classification for investigation, which is bedside, labs, imaging, and invasive investigation. The barium enema is not one of those investigations that we offer, but
Yes.
it's okay to mention it as well, as long as you mention others. Endoscopy, you need to be really clear if you're going to do a colonoscopy. So correct. So it's going to be non-urgent, and you would have to wait until the inflammation has resolved. Otherwise, you're risking a perforation for the patient. And if the patient is very unwell and you diagnose acute diverticulitis and they're currently septic and you worry about abscess, you want to do radiological drainage with laparoscopic lavage or emergency surgery like defunctional and Hartmann's procedure. All right. So you just need to work out a way to give an answer to this question in less than a minute. All right. So in about 40 seconds, you have to finish the answer, because otherwise it will take so long. The examiner will not even listen to you and you might end up losing marks. All right. So let's talk about endometriosis. What are the theories of endometriosis?
So there are 4 theories for endometriosis. The first one is retrograde bleeding, which is where you get a transcolonic migration of the blood from the endometrium into the colon. The second theory is the malignant theory. So this is where cells metastasize from the uterine lining or endometrial lining to the bowel via lymphatic spread or hematogenous spread. The benign theory is that it transmigrates to distant sites. And finally, you have the stem cell progenitor theory, which is where the stem cells of the mesentery or the colonic epithelium essentially go differentiate lineage into direct endometrial tissue.
Good. And why is endometriosis painful?
So endometriosis is painful based on 3 things. Number 1 is that you can get adhesions, so you can get endometrial adhesions causing pain. Number 2 is that you have menstrual bleeding. And number 3 is you get the release of substance P from pelvic pain.
So you don't, in endometriosis, you don't get an endometrial adhesion, right? Because the whole essence of endometriosis is that it's presence of endometrial cells outside the uterus, right? So you get pelvic adhesions, right? Or periuteric adhesions. So that can be very painful. And the endometriosis will be synced with the menstruation, and the patient can bleed into the abdomen. And that's why it's going to be painful, because they're basically getting an intra-abdominal hematoma. All right, this bleeding will not come out. That's why it's painful. And you will notice that the classic picture of endometriosis is that it's a cyclical pain, right? So it's very well synced with the endometrial cycle or the menstruation. All right. Does endometriosis increase the risk of cancer?
Yes, it increases the risk of ovarian cancer by 3 to 5 times.
Correct. So risk of ovarian cancer rather than risk of endometrial cancer. So I think good, you will find that I skipped some questions because these questions are actually never given the exam before, but I think it's a detailed guidelines for managing diverticular disease, just to get a bit of background when you're studying, but they're not necessarily needed. For example, later management of acute diverticulitis. We don't really touch base on that. We said we're going to do colonoscopy or C2 colonography on the later date until the acute diverticulitis phase subsides, and then you can do elective resection, or you can decide on an elective operation, basically, rather than an emergency operation. But I think these questions are not necessarily asked in the exam. But I think overall, very well done. You just need to, if we go back to the pathophysiology, this is a very important question. It's usually your opening question, and you need to make the opening question, it shouldn't go wrong, all right? So you have always to make the first question, you have to smash it and just make sure that you're giving a very good answer. Otherwise, the whole scenario will not go very well, all right? So to summarize that, so you have intra-abdominal pressure, intraluminal pressure, and
Yes.
the tinea coli, which is not a continuous band, but rather a 3 layers or 3 bands, and finally the vasa recta going through the wall of the colon. All right.